Hello, friends. So, good evening. So, I'll be giving a talk on this microcirculation and downstream markers, key insights. So, this talk I had to give as a part of a deliberation in a MaxCon conference that happened in Delhi by my good friend Dr. Rajesh Pandey. So, very interesting topic. I had covered actually on this topic as part of another lecture. Uh, so, and I've just added a little bit more into this topic which is of some relevance to the way we look into sepsis. So, what do we understand by microcirculation? So, I'll just show you these videos, friends. So, as you see, this is what microcirculation is all about. So, just carefully look at this video. You will see there are these small blood vessels with the blood flowing, and there is some sort of element of obstruction in some of them if you carefully watch it. So the way advancement is happening is we would really want to see how the microcirculation, what do we understand by microcirculation is at the capillary level, whether there is clogging of these blood vessels supplying the cells. So this is what we are interested in. I'll just show you another image where, see, this is how the colored microcirculation looks, where even there are technologies available to look into the areas which are being oxygenated. And this is in the on-course situation where they're looking at new sort of a vascular neogenesis that is happening and the effect of radiotherapy, so on and so forth. So this is the advancement that is happening with regards to ascertaining the blood flow at the cellular level. That is what we understand by microcirculation. This is a nice image, just if you see animated image. So this is the key essence or the key unit of microcirculation. So you have a blood going through the arterioles, then they go through these capillaries, and then the deoxygenated blood is drained from the venules. So this whole unit, what you see is called microcirculation, where you see this clogging of these sort of a micro vessels or capillaries, which leads to cellular hypoxemia. So, in essence, that's what is all about we are discussing. Are there any tools to ascertain whether there is clogging? If you see here, some of the small micro vessels are clogged here. So then there wouldn't be flow of blood and there is cellular hypoxemia that happens. So in essence, we are trying to see what tools can try to recognize and identify this microcirculation. So I have further simplified in this sort of a pictorial format. It's a very schematic one where you have a arterioles, then you have a venule, and there is a capillary network which is infusing energy into the cells from the oxygenated blood, and this is being drained off. So this is the simplistic sort of a unit that you can construct. And because of the arterial sort of a circulation, the cells are nourished with nutrients and oxygen. But there is some sort of a balance between the oxygenated blood that goes into the cells and the drainage of deoxygenated blood. So there is some sort of a balance which is maintained by autoregulation. And even the regulation of temperature happens by maintaining some sort of a balance in this microcirculation. And what is it that attains or that maintains the milieu, internal milieu, or the balance between the arterioles and venules and the microcirculation? So the control mechanisms are sometimes local and systemic. So what are the systemic control mechanisms which maintains the milieu or the harmony in this sort of a microcirculation? So autonomic nervous system, and you have renin-angiotensin system and vasopressin. So these are the tools in the body which maintains the balance in the microcirculation. And these are determined by the basal tone of the cardiovascular system and the plasma volume, which sort of maintains the decorum or sanctity of autonomic nervous system and renin-angiotensin system and vasopressin. So, so the whole microcirculation homeostasis is maintained by systemic factors and local factors. Systemic factors are autonomic nervous system, and you have renin-angiotensin system and vasopressors. And what are the local factors are more predominant sometimes. So I'm sure most of you know what are the local factors. Local factors are certain chemicals that are produced by the endothelial cells in the blood vessels, and the predominantly it's a nitric oxide, which is a potent vasodilators, prostaglandins, and thromboxanes. And there are other sort of agents like ADP, bradykinin, histamines, and substance P, which are sort of chemicals which trigger the production of nitric oxide by the endothelial. So these are endothelial cells in the blood vessels which trigger the production of nitric oxide by the endothelial cells. Then there are these adenosine, potassium, hydrogen, and carbon dioxide, which causes vasodilatation. So these are all the agents which are potent vasodilators, which cause the shock in a patient with sepsis, because we are discussing about what happens in sepsis. So nitric oxide, as you would know, is a vasodilator, which possibly is one of the quintessential chemical which leads to vasodilatation in sepsis. So what happens in sepsis? So this is the internal milieu as to how homeostasis is maintained in the microcirculation. So what happens in sepsis? So in sepsis, as you see, there is inappropriate vasodilatation or inappropriate constriction of this microcirculation. Because of this, there is lot of there is a structural sort of a integrity which gets lost in this microcirculation, and there is release of proteins in the cells, which typically you would see in a condition like ARDS. And there is increase in the heterogeneity with regards to the nutrients getting into the cells, which leads to there is a cellular oxygen delivery comes down and cellular hypoxemia comes down due to inappropriate constriction and dilatation, and that sort of a auto-regulation that is maintained in the microcirculation is lost, and that leads to reduction in the oxygen delivery and cellular hypoxemia that tends to set in. And because of this inappropriate constriction and dilatation, so there is a reduced responsiveness of these vessels to certain agents that you would give, and that is perpetuated by nitric oxide again. And in sepsis, L-arginine is converted to nitric oxide by nitric oxide synthase, and this nitric oxide causes activation of guanylate cyclase. And this particular activation of guanylate cyclase converts guanylate triphosphate to cyclic guanylate monophosphate. I'm sure all these chemical pathways you would know. Why this is important is this is the pathway which is needed for relaxation of the smooth muscles in the blood vessels, which lead to hypertension. So basically, nitric oxide remains at the background. And the way nitric oxide works, it causes activation of the guanylate cyclase, which leads to conversion of GTP to cGMP. And this leads to upregulation of the phosphate kinase. So it causes upregulation of this. And this upregulation of this protein kinase leads to the relaxation of the smooth muscles, activation of the potassium channels, and it inhibits the calcium uptake by these smooth muscles. And because there is a relaxation of the smooth muscles in the blood vessels, there is a vasodilatation and hypotension that happens. So this is the chemical pathway which is triggered by the nitric oxide. And nitric oxide synthase, they have three variants. So nitric oxide synthase inhibitor, inducible nitric oxide synthase, and endothelial nitric oxide synthase. So these are the three different types of nitric oxide. But in that, the inducible nitric oxide synthase, in the presence of cytokines and endotoxins, get converted into nitric oxide. And this nitric oxide, as you know, is a vasodilator, and endothelial nitric oxide synthase is what is needed to maintaining the vascular tone. So these are some of the chemical things that leads to vasodilatation and loss of integrity of the microcirculation. And we need to understand in sepsis, the density of the microcirculation tends to come down. If you see this very carefully, there is microthrombi formation in the venules, and this leads to ineffective microcirculatory surface areas tends to come down. So the microcirculation, because of the clogging of these small microvessels, the density of the microcirculation comes down, and there is increase in the reactive oxygen species, and there is superoxide with nitric oxide, which leads to peroxynitrate. All these have deleterious effect on the microcirculation. So basically, this slide, what is essentially showing is the fulcrum of the whole cascade of the vasodilatation is triggered by nitric oxide. And there are three variants of this, which are nitric oxide synthase inhibitor, inducible nitric oxide, and endothelial nitric oxide synthase. And all this leads to this whole chemical reaction where there's upregulation of phosphokinase or protein kinase, sorry, and there is a relaxation of the smooth muscles, which lead to hypertension. These are the sort of chemical pathways that happens at the microcirculatory level that leads to hypertension is what we need to understand. So now the question is, what is the importance of microcirculatory assessment in sepsis? So it is shown that when there is an improvement in the microcirculation, the organ dysfunction tends to be getting better, or there is reduction in the organ dysfunction. But if the microcirculation is dysfunctional, it is shown to worse have worse clinical outcomes. But the whole problem is measuring microcirculation is difficult. So rather, we monitor macro hemodynamics and take it as a representative of microcirculation, which is not the case. So what do we look at in macro hemodynamics? We look at systemic arterial pressure, we look at cardiac output, we look at heart rate, we look at mixed venous saturation as a tools to determine, and we try to convince ourselves that yes, macrohemodynamics are good, that's why microcirculation also is good, which is not that true. Because even though your systemic arterial pressure is good, cardiac output is good, heart rate is good, not necessarily improvement of this leads to improvement of microcirculation, which means you may improve systemic arterial pressure, you may improve cardiac output, but not necessarily that means that you have been successful in improving microcirculation. But noradrenaline is shown to inhibit the microcirculation or worsen the microcirculation. That is something we need to keep in mind. So when you look at the assessment of microcirculation, what are the tools that we have at this? So we have understood microcirculation is at a capillary level where circulation is impaired is what is called microcirculation. Do we have any tools? So there are indirect tools. The indirect tools are tissue oxygenation, tissue carbon dioxide, mixed venous saturation, lactate. So we know lactate goes up, and I'll show you the lactate cycle because that is happening at a cellular level and near infrared spectroscopy. So these are indirect tools to measure microcirculation. The direct tools are a little more complicated. So you have laser Doppler, then you have microscopes basically to determine how the microcirculation is happening. And studies have been done at a sublingual level to look at the microcirculation because sublingual is a easily accessible microcirculatory area. So they have looked at orthogonal polarization spectral, side stream dark field, and incident dark field. So these are the tools that are available to look at direct measurement of microcirculation. And then you have incident dark field, which I said, and dynamic, you have vascular occlusion techniques. I believe going forward in the future, vascular occlusion technique seems to be something that should possibly evolve and may become a bedside tool to assess microcirculation and looks more promising to me. So now we need to understand lactate because lactate is a marker of microcirculation. So what do we understand with lactate? In aerobic conditions, pyruvate is converted to acetyl-CoA in the presence of pyruvate dehydrogenase. This acetyl-CoA enters the Krebs cycle and forms the cofactors with oxidative phosphorylation 36 ATP. So this is the normal energy that cell needs, and the normal energy that cell gets is through this pathway. By the Krebs cycle and production of 36 ATP. But when there is an anaerobic conditions, you saw that nice unit where the arteriole is sending oxygen to the cells, and this is impaired. Then there is anaerobic conditions. So pyruvate, instead of pyruvate dehydrogenase, the lactate dehydrogenase converts pyruvate to lactic acid. And this lactic acid gives rise to lactate and hydrogen ions. But this lactic acid produces some ATPs, but not 36 ATPs. It undergoes glycolysis to produce some ATPs, which is not sufficient for a good energy production. So what happens is typically when there is cellular hypoxemia, because there's not much oxygen going to the cell, there is increase in the lactate and oxygen delivery comes down, oxygen consumption comes down. This leads to cellular dysfunction. This is what we are here to understand. How can we establish this with the tools that we have with regards to ascertaining to what extent the microcirculation is affected? And we need to understand the lactate production independently happens due to activation of the aerobic glycolysis that happens in sepsis, where microcirculatory dysfunction may not be present. Just the fact that there is an activation of aerobic glycolysis, there is increase in the lactate. And we need to understand in sepsis, if the patient is already on beta blockers, the amount of lactate rise may not be as much as it would be in patients who is not on beta blocker. Beta blockers tempers down the rise in lactate, and the vice versa happens in liver dysfunction, where even though the sepsis is not that bad, the lactates may be high because of the B type of lactate, which tends to go up in liver. So there are certain caveats the way we interpret. Not all lactate is due to cellular hypoxemia. There are so many other reasons also is what we need to understand. So let's look at the tools that are available. We spoke about lactate, and we'll talk about near infrared spectroscopy, which is an indirect tool of assessing the microcirculation. What does near infrared spectroscopy do? it looks at the differential absorption of infrared between oxyhemoglobin and deoxyhemoglobin. And by looking at the differential absorption, tissue oxygenation is measured. So how does that happen? So just look at this schematic diagram where incident light is thrown into the microcirculation. So there is some sort of a absorption that happens here, and there is some reflection of the remaining infrared that happens. And this is directly proportional to the absorption coefficient and the tissue oxygen saturation. Don't remember the formula. Remember the concept that you give the infrared, some amount of infrared is absorbed by the tissues and some amount of infrared is reflected back based on the difference between the incident light that you throw in and the reflected light. You look into the tissue oxygen because you look at how much absorption tissue has done before it reflects away. The infrared measures the tissue oxygen saturation, which is measured by a modified Beer-Lambert law, where they use this formula. A stands for absorbance, and I stands for intensity of light, and C stands for the flow of the blood. So this is just a formulas that they have derived to calculate the tissue oxygenation. So has there been any clinical studies? Is this relevant? Yes, there are clinical studies. Kazarbashi, they have done calculated tissue oxygen saturation. It is shown if your tissue oxygen saturation is less than 70%, it had 2.8 times increase in the risk of ICU admission. So this was another study done from UK group. If tissue oxygen saturation was less than 75%, there was twofold increase in the mortality. And and even after your resuscitation, if there was no improvement in the tissue oxygen saturation, it led to non-survivors were there where tissue oxygen saturation did not improve with resuscitative measures. So these are some of the tools that we need to understand. We spoke about lactate metabolism. We spoke about near infrared spectroscopy and mixed venous saturation. I'm sure most of you know, we wouldn't want to dwell into that. Let's look into the direct tools that are available. I said direct tools are orthogonal, polarization spectral, side stream, dark field, incident dark field. So you basically use video microscope to directly measure the microcirculation. So you look into the density of the microcirculation, you look at the heterogeneity of the microcirculation, and it is shown that the video microscope of the sublingual circulation shows abnormalities of the microcirculation. It shows increase in the hospital mortality. So the incident dark field is a handheld, uses epi-illumination, and the image area that it looks at, incident dark field, is very small, 1.55 into 1.16 millimeter is the area it visualizes, which means a small area at the sublingual region. It looks into, it's a microscope and then interprets the type of microcirculation dysfunction that it has, but there's no major data with regards to diagnostic utility and values. And they have used orthogonic polarization spectral and side stream dark field. So these are large microscope. As you see, this is a reflection. So they place the probe on the sublingual circulation and they visualize the sort of sublingual circulation in the monitor. So, and this is operator dependent. There is an offline analysis, and when you put the probe and look into the microcirculation, I showed you in the first slide itself, they look something like this. So you have vessels, which some vessels which are not which do not have a great blood flow, which appears clogged. There are some other blood vessels which are quite open and with a good blood flow. So this is how your orthogonal polarization spectral and side stream dark field sort of a thing shows. So are there any measures? Are there any studies? Yes, there are a lot of studies. So in 2006, they came with some sort of a consensus as to what are the measures that we should look at when we are doing this direct visualization of microcirculation. So they agreed upon three measures. You can look at the density, you can look at the perfusion of the microcirculation, you can look at the heterogeneity index. And in sepsis, and there are certain derived variables. In sepsis, they look perfusion vessel density, which is called PVD, and proportion of perfusion vessels and microcirculatory flow index. All these three tend to come down in sepsis, and there is huge heterogeneity problem, and heterogeneity index tends to go up. Have they done a study? Yes, there is a microscope study. As the name sounds, micro is microcirculation assessment. This was done by Europe, published in 2015. So they took 501 patients and they looked at microcirculatory flow index. 17% of the sepsis patients had abnormal microcirculatory flow index. And these patients who had abnormal microcirculatory flow index, the odds of mortality, the odds ratio increased by 3.24. And heterogeneity index also was high in these patients where there is abnormal microcirculatory flow index, and proportion of perfusion vessels and perfusion vessel density also was significantly less in patients with sepsis where there was abnormal microcirculatory flow index. So which means to say they had a good correlation with regards to severity of sepsis and their outcomes. So, and these are all the different sort of measures that they took in the studies with regards to microcirculatory flow index. So this is just to indicate the type of formulas and the processes they put in place to calculate microcirculatory flow index, total vessel density, perfused vessel density, and proportion of perfusion vessels and heterogeneity index. So we spoke about indirect tools, we spoke about lactate, we spoke about near infrared spectroscopy, and we looked at direct tools, which is all the video microscopes, incident dark field, side stream dark field, and orthogonal polarization spectral. Now let's look into what really impresses upon me is the dynamic method of assessment where we use as vascular occlusive technique. Very simple to understand this. It's a brief arterial occlusion. So very simple. You put a blood pressure curve and increase the blood pressure curve to more than systolic blood pressure. And what you do after increasing to more than systolic blood pressure, suddenly release. So when your blood pressure goes up to more than systolic blood pressure, there is sort of a deoxygenation that happens. And once you release the cuff, there is reoxygenation. And when there is a resaturation, rather resaturation that happens, so there is small area you see here, which is a hyperemia. So like it's like a reperfusion injury. So first there is a desaturation phase, and then there is a resaturation phase. We quantitate the time to resaturation. So that is the way that you look at adequacy of microcirculation. Are there studies? Yes, there are studies. Carda et al. They looked at resaturation, tissue oxygenation time percentage is calculated as percentage per second. And as you see, they found that the resaturation in healthy was the time to resaturation was obviously much better in healthy, and the time to resaturation was less in patients with sepsis. So that is percentage per second it is taken as, and that was significant. And this was another Dutch studies. As you see, the tissue oxygen recovery happened in a much better way in healthy patients at 5.19, which is calculated as percentage per second. In sepsis, it was low, and in septic shock, it was much lower, which means the tissue oxygen saturation, resaturation was significantly less in the septic shock, and all was statistically, which means to say the resaturation tends to happen better in the healthy, lesser in sepsis, and worse off in septic shock. So, which means the tissue resaturation happens to a much lesser degree in patients with septic shock. So, this appears more promising for us to understand as to determining, and it's a more dynamic test. So, determining the severity of microcirculation and adequacy of resuscitative measures to reverse your microcirculation. And it was shown that the resaturation, where the resaturation did not happen well, it was associated with non-survivors, where the recovery, tissue oxygen recovery did not happen, was associated with non-survivors. So, which is again to show the severity of microcirculatory dysfunction was associated with non-survivors. And what about clinical examination? Mottling. Mottling also is an important tool to assess your microcirculation. So if you see a skin like this, so we have Andromeda study, which very clearly showed us that your microcirculatory dysfunction seen as a mottling is a good indicator of severity of the disease and outcome and the mortality. So you would have a cold periphery or delayed capillary refill is associated with microcirculatory dysfunction. So are there studies? Yes, there is this Andromeda study, I'm sure you know. So this was from the French groups where they showed that mottling was present in 46 to 70% of the patients with septic shock, and this was associated with increased mortality. And this was another study by France where if patient is come with mottling, they were found to have fourfold increase in mortality. And they've looked at skin temperature also, and now the mottling is able to be recognized even in dark patients by using infrared thermal imaging, which tends to pick up mottling much earlier on than the clinical sort of a mottling that we do. And Andromeda study clearly showed that your capillary refill time is sort of a prolonged, it had a direct bearing on the organ dysfunction. So we have good science to suggest that. And infrared thermal imaging is based out of this Stephen Boltzmann law. So that's about the whole microcirculation. And this image, what I'm showing you, is useful for all our trainees. So when we talk about microcirculation, don't look at it as the only component to do hemodynamic optimization. So this is a nice picture. I got it from one of the, one of the articles. So as you see, we have different sort of a points where we can assess hemodynamics. So all the round ones is the area. So very easy to remember and useful for trainees. So if you have someone with a CVC line and you want to do cardiac output monitors you can obviously use thermodilution with cardiac output, stroke volume, global end diastolic volume, extravascular lung water with using thermodilution technique. So basically this picture denotes try to utilize all the tools and synergize it and use it in as an adjunct in making a comprehensive assessment of your hemodynamic status. So obviously, if you have advanced tools like microcirculatory dysfunction with a video microscope, you assess the sublingual circulation. If you have a CVC line, so obviously you can look at mixed venous oxygen saturation or venous and arterial carbon dioxide difference, CVP, pulmonary artery occlusive pressures, if you have the PA catheters. And of course, you have to look at the echocardiogram and look for anything that you can find in echocardiographically to look at the causes of shock. As you see here, it's a tamponade causing obstructive shock. And if you have an arterial line, obviously you would look at lactate levels, you would look at arterial blood pressure, you would look at pulse pressure variation and heart rate. So, and don't ignore to look at capillary refill time at the fingers. And of course, you would look at urine output and always look at the mottling, and the mottling is first occurs around the knee joint, and there is a grading of mottling from 1 to 5, and the mottling tends to extend from the center of the knee and way above the limbs as shown in this picture. And then you can look at any presence of pedal edema, which also gives an insight about the hemodynamic status. And the last one is the central toe sort of a temperature gradient. So this picture basically encapsulates all the tools that may be available for you to use. So not every ICU will have all the tools. Whichever tools you have, use in conjunction and adjunct along with microcirculatory sort of an assessment to make a comprehensive sense and semblance as to what is the type of hemodynamic derangement that the patient may have. So summary of microcirculation, my friends, is our capillary unit, which is a representative of microcirculation, maintains the structural and functional integrity of tissue cells, and they do get profoundly affected in sepsis. Microcirculation at a capillary level do get profoundly affected in sepsis, which leads to organ dysfunction. And macrohemodynamics, which we so much believe in, which is systemic arterial pressure and cardiac output, so on and so forth, fail to assess microcirculation. So just because you have optimized cardiac output, just because you have optimized sort of the systemic arterial pressure or MAP, and you have looked into the volume status, they fail to assess microcirculation. So assessment of microcirculation, we have three categories. You can do direct, which is expensive and more fancy gadgets. So indirect is you can look at near infrared spectroscopy, or you can simplest thing that we can do at bedside in most ICUs is the lactate. So don't undermine the value of lactate. And vascular occlusive techniques look like a very promising sort of a dynamic way of assessing microcirculation, where you increase the systolic blood pressure more than the sort of a you inflate the cuff more than systolic blood pressure, look at the desaturation and the resaturation time. And dynamic microcirculation with thermal modeling is appearing more promising. So using these gadgets to assess thermal modeling appears feasible and holds promise. And thermal modeling gadgets are available in the screening of cancer patients already in the market. So we need to uh, sort of get its utility to be done in our ICU patients also. So that's about it, folks. So microcirculation is a concept that we all need to be aware of, and the tools that possibly we should be looking forward to is this vascular occlusive technique, which tends to assess the tissue oxygen saturation, and this thermal modeling. I think they appear very promising in days to come. So thank you one and all. So I request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to rehear to this lecture. Thank you one and all.